We'll stop talking about calcium for a little while and move on to this very ominous topic. So the evil lurking in the corner, ISR, no relevant disclosures. So we've heard a lot about all these numbers and the changes, but the main things that's been happening is that we've heard there's so many devices that now that we can use as an endo first approach. We have all of our balloons, atherectomy, DCB, drug-eluting stents, bare metal stents. This has resulted in a big shift away from a surgical first upfront approach. So we even know from our Medicare data from the 96 to 2011 population, there's been over 150% increase in endo first interventions. And this has corresponded to a 60% decrease in bypass surgery upfront. The problem is that when you have all these endovascular procedures and all these stents being placed, we also know that unfortunately about 30 to 40% of these patients will have some form of ISR within 2 years of the initial procedure. So why is this whole thing happening? So when you do any form of intervention onto the vessel wall, you will have, especially if you have ballooning, even with the inclusion of any drugs as well, with or without stenting, you have some degree of vessel wall trauma. This removes your endothelial layer, and then you can also have some rupture of your IEL and also your medial injury. This can then give you your vessel recoil, some negative remodeling, and some new intimal hyperplasia. At the end of all this, what you have is that you have a new lesion that's entirely different than what your original lesion was. And this new restenotic lesion has a completely different morphology than what you had actually begun with. So on the left here, you see your initial lesion. You have your adventitia, your media, your intimal, and you see your actual plaque. Now, after you've done your intervention, you have the stent placed. The ISR disease morphology is entirely different than what you had begun with. You have this dense cap of smooth muscle cells, and you also have this hydrated collagen matrix. It's very watery, and it can really take a big degree of your actual plaque volume. So there are two slides, histology slides, looking at two different morphologies of your ISR. Neither of these were stented, but it still does show the actual importance of what is happening histologically inside the actual vessel. So on the left, you see your basic ISR with the black arrow showing your medial fibrocalcifications and your necrotic core that is, we all know so typically well. On the right, though, you see something that's quite different. These are both tibial arteries, and you see the same fibrocalcific plaque on the blue arrow on the right, but then you see that the majority of the lumen is actually filled up by the black arrow, which is all thrombus. So what's the importance of this thrombus? The thrombus is what kind of drives all of our acute limb events. We know that the presence of thrombus can give you higher rates of ALI, major amputation, urgent limb revascularization, and people just become more and more symptomatic very, very quickly. And this also correlates with all of our MACE outcomes, higher rates of MI, cardiovascular death, and even other forms of heart failure, CVA, and so on and so forth. Now, those two slides showed the two different types of ISR that we can have, and why is that even important? So we have three different classes that this group was kind of identifying, and we see that you can either have focal ISR, where you have your entire vessel is not occluded. You have very focal lesions, either in the middle, in the beginning, or the end. And then you have another version of it where you can have ISR that's kind of diffuse, going along the entire length of your stent. And this we see all the time, where you've deployed a stent, you bring it back, and you see that there's a little bit of irregularity to the lumen that you see from the angiographically, but the stent itself is still open. Or, it's not, I wouldn't say patent, but there is still antegrade flow going through the actual vessel. The last one is where you have complete occlusion. It's all gone. So what does that correlate to? On the right, you see that this last class, where you have complete occlusion of the vessel because of the totally occluded lesion, they have the absolute worst outcomes. The first two kind of do somewhat similarly. But the last, when you have the complete occlusion, they do markedly worse as far as their patency moving forward. So now we have this idea of a filter or thrombus in the background. So is a part of the way to treat this is could we understand what's going on with what's be catching the filter? So there was a study that was performed that was basically all these ISR patients. They underwent intervention with a filter, and then the debris from the filter was then analyzed to see what exactly is in there. And all these patients, they had regular ballooning, stenting, atherectomy, aspirations, all these things. And the interesting thing was that when the interventionalists were doing the procedures, they were asked, do you think that this lesion angiographically does it appear thrombotic? And on the majority of them did not really think so. But when they did actually go through the actual material from the filtered debris and did the histological analysis, a lot of them did actually have a good amount of thrombus. So pre-treatment, we saw that the 90% of them did not appear to be thrombotic. And after they did the core lab analysis, they found that over half of them were. And oddly enough, same idea was with the calcium, was that they thought that this was a highly calcified lesion, but what they thought was actually 90% calcium was actually less than 5. So it's not so cut and dry. And we do see that there is definitely more thrombus than we typically think. So there's definitely a component of thrombus. Now, if we then put this in the back of our mind, the thrombus, we know that this is something that portends to worse outcomes. What should we do to make sure we minimize the risk we provide to the patients when we are doing an endo-first approach? So we have your EPDs, we have all of our different atherectomy devices, we have our mechanical aspiration, and then we have the drugs we use to the devices we use to limit the rates of ISR, your drug-coated balloons, your drug-eluting stents. All of you in your own facilities will have your own closet full of EPDs, whether you use your spiders, your NAV6, et cetera, so on and so forth. Just keep in mind that the device you use as your adjunctive therapy or your destination therapy will be somewhat limited based off your EPD that you end up using. For example, if you want to use a directional atherectomy, but you want to use a device like the NAV6, remember that your distal lesion of where you're going to be treating with your directional atherectomy, the nose cone has to be far enough to your actual EPD. Otherwise, then all that stuff you've been using your filter for, now you're going to be dislodging it and kind of undoing all the protection you had done up front. So a few nuances in terms of your selection of your protection devices. Now, what are the atherectomy approved for ISR? The laser, all of you know it from the big tank. This comes into the room. They have a few different types of actual properties of how they actually treat the actual ISR, as Asma had gone over. There's a photochemical, photothermal, and photomechanical. All these have resulted in a lot of trials. The main trial is showing that the laser atherectomy plus PTA was better than PTA alone in the ISR and almost across the board. So we know that using laser for ISR is one outcome. That's actually one atherectomy device that we know will work very, very well. As Asma had also spoken about, the rotational atherectomy system of the Rotarex from Bard is actually one that has a combination of atherectomy and aspiration. They have a similar Archimedes screw that provides the aspiration as far as the actual rotating cylinder that will actually do the atherectomy part. A little upgraded version of Osmo slides with the videos, but mentioning the exact same thing that we're talking about. And we do have the exact same slides. But this is just showing again the role of the Rotarex system. And again, this is approved. In my personal practice, this has been one of my favorite new devices for tackling ISR, especially the ones that have complete occlusion through on it and through. A short word about what is a drug-coated technology to use in the ISR. This somewhat complicated slide is saying two very simple things. BMS ISR, let's see if I can get my mouse here. I can't. Okay, so there it is. So BMS ISR tends to have better outcomes than DES ISR. That's just that's the basics of what this slide is showing as far as the Restenosis outcomes, overall outcomes for patients. Now, in terms of using drug-coated balloons versus drug-eluting stents, for BMS ISR, both of them work very, very well. But if you are looking at DES ISR, a drug-coated balloon technology actually does not do as well as doing as another drug-eluting stent for DES ISR. This was a study that was published a couple of years ago, but it's important to kind of keep this in the back of your mind when you're tackling your ISR lesions. What is a form of ISR? What is a stent? What was the drug? Was there a drug? So on and so forth. Finally, we'll end with just a quick word about your antiplatelet therapies that are going to be given to the patient afterwards. Just keep in mind, we've been talking a lot about the Voyager PED trial, so we know that there are new kits on the block that may be better than our typical DAP that we do so regularly. So aspirin is relative should be something you also consider. And with that, thank you.